right, so take 5 seconds to pause the video and read the question, and then we'll go through the answer. All right, so we have a 57-year-old male coming to the urgent care clinic with numbness of his right foot and shortness of breath. Okay, numbness of the right foot, shortness of breath. States that he has had 3 fall episodes over the past month because he can't feel the floor. Okay, so some sensory deficits here. He denies any dizziness and reports that he has not been seen by a physician in over 20 years. This is actually a very critical piece of information in a lot of these questions, but let's keep reading. So physical exam reveals a left internuclear ophthalmoplegia. What is this very classic for? So if you've watched the neurology series, we've talked about this. Very classic for multiple sclerosis. The pupils accommodate but are not reactive to direct or indirect light stimulation. So I was just going to say, is this male is 57 years old. I mean, usually if I get an MS question, it's going to be, a female in her 20s, 30s, 40s. I mean, it's very not classic to have a 57-year-old male asked about the MS. Now, in real life, it's not impossible, but it's just not the classic kind of board question. But what I was just going to say is that pupils accommodate but are not reactive to direct or indirect light stimulation. So what is this talking about? That's talking about the Argyll-Robertson pupil. Okay, now there's only 2 situations where you really classically see this. Number 1, it's going to be in syphilis. That's 4 to 5 times. What's that other 1 out of 5? They sometimes bring this up in Parinaud syndrome. But this is not a neurology question, as you know by watching this video. So let's keep reading. Locally destructive ulcerative lesions are present diffusely throughout the face and back. So really thinking about syphilis. Now, cardiovascular exam demonstrates a high-pitched diastolic murmur, most prominent at the left fourth intercostal space, left sternal border. Pulses are notable for rapid upstroke and downstroke. Okay, so, when you start to see this is the water hammer pulses, right? So very classic for aortic regurgitation because you have a huge discrepancy in the pulse pressure. Remember, we talked about that because you have to have a really high pressure to get the blood out, and then the diastolic pressure is lower because a lot of that blood backflow. So the systolic pressure is very high, diastolic pressure is very low, and you see that in the pulse with this water hammer pulse. Rapid upstroke and systole, and then you have this rapid downstroke because of the regurgitation. Okay, so reflexes are going to be hyporeflexic. That's because this patient probably has tertiary neurosyphilis. Sensory ataxia is present, right? Surprise, surprise, patient probably has tabes dorsalis. That's the presentation they're giving us for this tertiary syphilis. We have a biopsy here. Usually you're not going to see too much on the biopsy unless you're looking for treponemal parasites. Specifically, the patient is referred for an LP, which is normally what we would do. We'd want to get like a VDRL or something like that on the LP and the CSF because we're concerned about neurosyphilis. Okay, so the question though, which of the following best demonstrates the time along the left ventricular pressure volume loop that this patient's heart murmur will be most prominent? Okay, so most prominent. So, let's just kind of analyze this. So we talked about A is being the point where the mitral valve closes. So number 1, we know that these are the isovolumetric phases. Now you might be saying, well, how come if they're the isovolumetric phases, why is the volume changing? Because this patient has aortic regurgitation. That's why the volume's changing. Normally these should be straight lines. Remember, we talked about that. That's not a straight line, but normally they should be straight lines, something like that. But they're not straight lines because we're regurgitating blood, okay? Because we don't have all the valves closed. We don't have a closed system. So this should be isovolumetric contraction, and this should be ejection, okay? So this whole phase, when the mitral valve closes, right? This is mitral valve. When the mitral valve closes, this whole phase is systole, okay? So that whole phase is systole, which means when the aortic valve closes, which is around point C here, somewhere around here, here's my aortic valve closing. When the aortic valve closes, from this point on, I go isovolumetric relaxation, right? And then I have ventricular filling. This is all going to be diastole. Okay, so I have systole and I have diastole. Now, they tell you in the question, it's a diastolic murmur. There's only 2 major diastolic murmurs: aortic regurgitation, mitral stenosis, right? Those are the 2 big ones. Okay, so you don't even have to know that it's aortic regurgitation. You know it's a diastolic murmur. You know that it's a high-pitched murmur, right? So you're thinking high-pitched murmur, look at the location, left fourth intercostal space along the left sternal border, and they give you some other signs suggestive of aortic regurgitation. If this was mitral stenosis, what point on here would it be most prominent? Well, mitral stenosis has an opening snap. Mitral stenosis has an opening snap. So it would probably be, mitral stenosis would probably be right there. That's where the mitral valve opens at point D, and then we go through ventricular filling. So that's where the opening snap would be if it was mitral stenosis, right? But it's not mitral stenosis. It's not at the apex. We're at the left fourth intercostal space. All right, let's go through these other options really quickly. What about distance between A to B? So this distance is in what phase? Systole. Where's my murmur? In diastole, right? So it's not A to B. And for that reason, it's not B to C either, right? Because B to C is also in systole. Now, what murmur would be really classic to see it from B to C? This would be very classic at this spot if the patient had aortic stenosis, right? If it was a crescendo, decrescendo murmur, radiation to the carotids, if it was in systole, right? These would all be very classic for aortic stenosis. But again, it's not a systolic murmur, it's a diastolic murmur, okay? So it can't be in these phases. So that's how we can rule out A and B. So now we're left with C and D. Now remember that aortic regurgitation is happening because we're regurgitating blood backwards from the aorta. We're regurgitating blood backwards from the aorta back into the left ventricle. Normally, my left ventricle is ejecting into the aorta, but I'm having some of that regurgitate backward. Now, the question is, when's that going to happen? Well, my aortic valve closes here, and then I have this huge drop in pressure. When I have a very rapid drop in pressure, where's that blood going to go? The blood's going to move back because of this rapid drop in pressure. As soon as I go down this, look at the slope of this, right? It's a huge drop in pressure. And notice as I'm dropping, my curve is moving to the right, okay? So as I'm moving to the right, I'm getting regurgitation of blood backwards. And the most regurgitation is going to happen when the pressure drop is the greatest, right? In this region right here. That's why aortic regurgitation is an early decrescendo murmur, okay? In other words, when the aortic valve closes, if this is my aortic valve closing, right, what's going to happen is I'm going to get a murmur that looks something like this, okay? It's going to be decrescendo. And this is all happening in diastole. Decrescendo meaning that it's going down in amplitude. So it starts high because of the huge pressure drop, and then you get a little bit of blood, okay, regurgitating. So the most blood that's going to be regurgitating when the heart murmur is the most prominent is early in diastole because it's a decrescendo murmur. At the steepest and most rapid point of pressure drop when we'll have regurgitation, and that would be between points C and D in diastole.